Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Today I'm joined by Nick Strasser. He is a foot and ankle orthopedic surgeon down in Nashville, Tennessee. Thank you for joining me today, Nick.
Yeah, it's great to be here. Thanks for the invitation.
Yeah, absolutely. So, Nick, going back to your history, you went to medical school at the University of South Dakota. You did your residency at Mayo Clinic, Ortho Carolina Foot and Ankle Fellowship. And then after that, you served as a team physician at both University of Oregon and now at Vanderbilt University. And also while you were in Oregon, you served as on-site medical coverage for the U.S. track and field Olympic trials. So a lot of sports medicine in there. Is that one of your passions?
Yeah, I would say that's kind of my big interest, I think, in foot and ankle surgery when I first started looking at different subspecialties, I guess. You know, sports was pretty high up there, but I liked foot and ankle a lot as well. And what I liked about foot and ankle is I had a little bit of a tough time kind of deciding what I wanted to do because I liked the sport aspect, but I also like total joint, recon, trauma, that kind of stuff. And what I really liked about foot and ankle surgery is you cover a lot of different areas of orthopedic surgery when it comes to managing, some of these patients. You can get aspects of each. And so I decided to do foot and ankle, and then it was able to do it at Ortho Carolina, where we did a lot of sports, and it kind of maintained a passion and a big part of my practice.
Yeah, that's great. So I have a big interest in sports medicine as well. So we have that in common. I'm a big Iowa Hawkeye fan. So I don't think the Hawkeyes and the Vanderbilt Commodores overlap very often.
No, I don't think so. But I think Oregon and the Hawkeyes will probably overlap at some point here coming up pretty shortly.
They sure will now, won't they? So what's kind of your favorite thing about doing foot and ankle surgery? Obviously the sports medicine component of that, but you can only see so many athletes. So you like the reconstructive part of it, you like the injury part of it, or what would you say is your favorite kind of aspect of what you do?
I don't know that I have like one particular area that I necessarily, obviously, the sports piece, but, I like the variety of care in foot and ankle, and I like being able to kind of have a little bit of a subspecialized knowledge of something. At least coming out of orthopedics, there's a lot of people that would say, maybe similar to hand surgery, where they're like, I don't want to manage any of that. And I think it's kind of fun to have that unique understanding of foot and ankle care and some of the nuances of some of the things that we treat, whether it's like posterior tibial tendon dysfunction, or like Liz Frank injuries. I think those have a lot of nuance to them. And so kind of figuring out what it is that works and what doesn't work, I think is really, it's been really fun. Kind of have almost, develop that mastery of something that not a lot of people have.
Yeah, absolutely. I think it's a little more complicated than maybe sometimes it gets credit for. At least maybe you and I are both a little biased in that, but I think you start talking about reconstructive surgery and all the angles and, is it a cavus? Is it an overcorrection? Is it an undercorrection? And sometimes you don't know until you do it. And then you realize, I could have done that a little better. So maybe a little more complicated than some people give it credit for, but obviously you and I might be biased from that aspect.
Yes and no. Biased, yes. But, when in one of my previous jobs, I did lower extremity surgery. So I had the opportunity to a lot of trauma in general, like just, whatever kind of came in. So it could be upper extremity, lower extremity, and recon. So total hip, total knee. and knee arthroscopy, things like that. And so one thing that I appreciated, there definitely was a greater challenge to the foot and ankle cases. There's so many factors in play, different joints that you have to consider. Sometimes I was more excited about seeing a patient with knee arthritis or hip arthritis because it was a pretty straightforward workup a lot of times, and and managing that was straightforward. Not that that there can't be challenges and things that come up that you have to know how to manage, but there is something to being said for that type of patient as opposed to somebody with ankle arthritis and foot deformity. How are you going to manage that? Is it staged? Like, there's so many subtleties that you have to know how to manage that. I think it's given me a deeper appreciation, even since coming out of training, of what we get to do.
Mm-hmm. Absolutely. So you and I kind of met, if you call it that, through social media and kind of online, but kind of going back, I didn't quite put two and two together that I had been listening to some AOFAS podcasts and then kind of put two and two together that, oh, that's him. That's the guy who does a lot of those AOFAS podcasts. So how'd you get involved with doing the podcast for them?
Really, it was just bothering them until they let me be part of it, to be quite honest. When one of my friends, Ben Jackson, he was R4 when I was a fellow. We got to know each other, so a number of years ago, and he was on that committee, and I heard him do a couple of them, and I said, hey, I'd love to be involved with this if there's ever an opportunity. And he floated it to the committee, and they let me be part of it, and it's been a lot of fun to be part of. It's been a big learning curve. I think back to one of my first interviews with that we were doing like total ankles and putting that all together. And you think kind of how you want to run everything, and then the conversation gets going and it feels a little bit different. And so figuring out how to work through that, navigate that, ask the questions, I think has been it's been a good learning experience. And at the end of the day, it's just being curious about a lot of different things that I don't necessarily have the answers to. And so it gives me an opportunity to meet different people, gives me an opportunity to ask the questions that I've always wanted to know. So I've really enjoyed it.
Yeah, that's what I find interesting about me sitting on this end of this podcast that I kind of created out of thin air. I guess I got tired of nobody asking me to be on a podcast. So I thought, well, maybe I'll just make my own podcast. And then if no one listens, I won't care, but at least then I'll feel like I'm on a podcast. So I feel the same way. Talking to people, learning, I find it very interesting. I do try to do some research ahead of time, and kind of humbles you in realizing, wow, I've never read this article before. I didn't know this. And, oh, that's how you do it. That makes a lot of sense. And so, as much as I put this out there for hopefully people to learn from, it's selfishly, I have learned a lot too. So I agree with you.
Yeah, I think I've listened to a lot of podcasts and different learning platforms. And what I like about it is it gives me the chance to be able to really ask the questions and focus on things in the way that have been wanting to listen to or wanting to hear. And I think that hopefully is helpful, because chances are if we have a question on something, we're not alone in that. There's other people that have the question as well. So it's a learning experience, but it's been a lot of fun as well.
Yeah, I think it's a more entertaining way to learn. I think kind of the world is moving toward podcasts. The amount of time people spend going to and from jobs in their car, it's easy to listen. It's easy to get bored when you're sitting in front of a lecture and they kind of start talking about all the stuff that you've heard 50 times. And then at the very end, they might get to some interesting things that you hadn't thought of before. But I think podcasting allows you to kind of take a deep dive into each of those topics. So like you said, when you start talking about total ankles, you can spend a good amount of time on there. Whereas in these lectures that you go to at conferences, maybe they're 15, 20 minutes. They're trying to cram a bunch of information in there. So it feels like in this arena, maybe you can let it breathe a little bit and kind of get into some nuances, like you said.
Mm-hmm. Most definitely.
So you also have another, which I don't know if you call it a podcast, but it's a YouTube-based podcast, we'll call it, called Orthopedic Indications. You were kind enough to invite me on, and we had some really good conversations recently. So how did you get involved in that? You start that up?
Yeah, I guess kind of out of thin air, like you said. It was a scenario where realizing that there was, I had a rep reach out asking to join our indications conference. Every week we have a indications conference. We talk about pre-ops and post-ops, and I was just like, I don't know if we can do that from just a HIPAA perspective, but why don't we do something like that? We do it based off of a topic, and then we do case-based, discussions, and we just talk through. So I reached out to my friend Jan, who he and I were co-residents, like a year apart at Mayo. And so, and he does a lot with ortho bullets and education. And so I said, hey, would you want to do this with me? And we just kind of put it out there, and, I don't know, it's taking off. I don't know if that's the right term, but it's been well received, I think. And really what we do is we focus on talking through foot and ankle cases, and really focusing on it for those who are in medical sales. And, realizing that they have it's a very broad background, right? I mean, there's people from business, people who are techs, there's one that I work with, he's a dietitian background, and they're all learning all these different, areas of orthopedic surgery, but not really having a great platform for them to learn some of the things. There's certainly like education, this medical college kind of thing, this, really core, this really crash course basics of being a medical sales rep. But this was an opportunity to set something up, kind of like you said, more of a deep dive into some of these cases. And we do it based off of case-based learning. So we might pick a topic like ankle fractures, and we'll pick 3 or 4 different ankle fractures, and we do it live. That way they can get on, they can ask questions. And we just do it over Zoom. And then I've just kind of broken those down into smaller video chunks, and then put those onto YouTube and onto a YouTube channel. And I've done just YouTube at this point, just because of the visual, being able to see the X-ray, see what we're talking about, I think is so valuable. But, you're kind of making me think a little bit about turning it into a podcast as well, just with what you've done, because I think you've been able to do that successfully. So it's certainly something to consider going forward. And then we also have a little newsletter that we do, mostly just to announce when we're going to meet. It's not overly annoying newsletter, but to announce, hey, we're meeting up this Wednesday at, whatever the date might be. It's not actually this Wednesday, so if you're listening to this, but just we do it for an hour. You can ask questions. We encourage questions from those who are in the audience to put in on the chat, and that helps us shape the discussion. So we make sure we're staying relevant to what is valuable to the learning.
I think that's great. I think you bring up a great point there. When reps start, they don't have most of them don't have any training in one specific field of medicine. It's a common profession for ex-athletes. Maybe they've been in medical sales before, but kind of talking their language and letting them kind of see your thought process from the inside, I think will really help them, not only help you, but help whoever they're working with in the OR. I find it a struggle for me in this platform to try to talk to all ages. I have students who listen, residents who listen, and then attendings who listen. And if I speak a certain way, I'm either talking down to the attendings or talking way over the head of the students. Mm-hmm. It's hard to find that common balance. So I try to have some episodes that kind of hit each of those things, maybe for each of those people. But I think that was kind of a neglected niche that you hit on there, because there are so many medical device sales reps in the country, not just in foot and ankle, in any area, but providing them that resource, I think, is great. Have you gotten a lot of good feedback from that?
Yeah, I think for what we're doing in the target audience, they've said it's been very valuable for them. I try to keep it kind of industry agnostic. Obviously, you see, whatever we're using in a particular case, and we talk about what we're using so that they know, that way, if they have a product that might be similar, or if they're in a case with a physician and they can make a suggestion on, whatever that might be, we might have. And it could just be in terms of sizes. So, I mean, you've probably been in these cases before too, where the rep from company X is opening stuff from company Y stuff because there was something contaminated, or it's missing that particular size in that tray. So I think just having that, getting them an understanding of, what other options they might have really is the goal of that whole thing, to just have them feel more comfortable. And then I like breaking it down so that if they have a case that's coming up in the upcoming week, that potentially they could go back, listen in on how we talk through that case, and then they just kind of have a refresher, real quick 10-15 minute refresher on that particular case.
Yeah, I think that's helpful. I've certainly had reps, like you said, open other products. I've had reps, suggest things that other doctors have done if something isn't quite going quite right. Oh, have you tried that? So having the reps be as informed as possible is actually a benefit to the surgeon as well.
Yep.
As much as we like to sometimes think, well, I know how to do it, I got plan B, I got plan C, there's been numerous times where they will say, well, I saw a guy or gal do this one time. So I think that's...
You have to be a little careful with depending on knowing your audience. Maybe that's the key with that is that might bristle some surgeons if they say, well, so Dr. So-and-so, who's the competitor across the street, does it this way.
That's true.
But, and then, the other thing I realized is sometimes the person that knows your nuances, not only just the case, but just the nuances of what you do that maybe is with you the most frequently, it may be your rep. And so just whatever you can do to kind of keep them as part of the team, I feel like they get a bit of a bad rep, I guess, pun intended. They get a little bit of a bad rap on, they're just like a salesman and stuff like that, but they really do care. They want the case to go well. And granted, it might be because they want their product to do well and they want to sell it. But they also want they're not going to sell it if the patient doesn't do well. So they really are invested in what they're doing and wanting to get a good outcome, have a successful result. And I just think that they're part of the team and the critical part of the team, and having that opportunity for them to be able to kind of expand their knowledge in a way that is pretty low key. And I think in a way that is helpful and applicable rather than just like lecturing of, like you said, like just kind of this dry lecture. It's more of an interactive discussion.
Yeah, absolutely. So I think you hit on a necessary area there. So what do you think about jumping into some cases here?
Yeah, let's do it.
All right. I always have to pause on my introductory screen because I spend enough time on it that I can't just breeze through it. I have to do like a 3 Mississippi here and enjoy my work that I put in here.
That's good. That's good. I like it. You need to get to the point where just have AI do it.
Yeah, there you go. You do my whole job.
Yep.
All right. Why don't you take off here? Tell us what we're looking at.
Okay. So, I put this case together because this is I don't remember the exact age. I want to say mid to late 20-year-old female patient that comes in that sustained a ankle injury, just like a common ankle sprain. And it was a year and a half before she presented to my clinic with these x-rays. And I think the reason I brought this case up is because it's been on the forefront of my mind, thinking about, ankle sprains that don't get better, putting together some lectures and then seeing some patients that come in, because you really have to be aware. You have to be careful to look for things that sometimes get missed or don't get recognized. And this was kind of one of those cases where, when you look at her x-rays, she has that osteochondral lesion on the lateral dome of her talus. And now she's been dealing with for a year and a half. And she had some other social situation that came up that she wasn't able to get in sooner, but was seen initially. Now, I have no idea what the x-rays look like on initial presentation. It might not have seen anything, and this might have shown up. But I think it's a good reminder that there's a number of conditions that can come up that you don't want to miss when somebody comes in with just like a sprained ankle. And, you and I know this, but I think it's worth mentioning that an ankle sprain, I feel like it's kind of poo-pooed as, it's just a sprained ankle. It's like no big deal. But the reality is there's 2 million that present to the ER each year. So they're common, very common. And there is a fairly high rate of chronic problems related to it, whether it's ankle instability or other injuries, as in this case, this traumatic osteochondral lesion, things like Liz. I just took care of a gal who was seen with a Liz Frank injury, and was told initially that, oh, it's just an ankle sprain. So I think just maybe calling that to attention, that you got to be really thinking about a bunch of different conditions when you come in with just a quote unquote sprained ankle.
Yeah, I think that's a good point. So I don't want to say well-trained. That sounds like I have more power than I do. I was going to say I have my ER and my urgent care well-trained, but we work cooperatively to make sure that these injuries follow up and they don't just tell them, oh, you sprained your ankle, put you in a boot, and off you go. So, working with your referring providers, whoever that may be, family practice, urgent care, ER, whoever sees them initially, if it isn't you, making sure that you kind of explain, well, here's a few things that it could be that aren't just an ankle sprain that we don't need to miss, whether it be osteochondral lesion, peroneal tendon pathology, whether it is a significant lateral ankle sprain, whether it's a syndesmosis injury. Like you said, it could be something completely different, like a Liz Frank injury. They didn't get any foot x-rays because, maybe they sprained their ankle also, and so they're pointing to their ankle. So I think obviously that injuries are going to go missed. That's the nature of things, and sometimes they slip through the cracks for whatever reason. But us on our end of it, making sure that we don't miss these injuries, I think is the important takeaway. I can't control if the initial provider sends them on to me or tells them to follow up. I can discuss that with them, but I don't really have control over that. But making sure that you and I don't miss these injuries, I think, is important. So what was your plan after you got these x-rays?
Well, so after this, I got these x-rays, and you kind of have like an initial discussion with them. I tend to get an MRI pretty routinely on these. That's a little bit of my workup. And I usually tell them I'm probably going to get a CT scan as well. I'm curious as what what does your imaging look like, or what do you get for advanced imaging in a case like this?
So I agree with you. I tend to get an MRI. From that standpoint, I can usually see what I need to be able to see from the MRI. I try not to, miss these things on x-ray. And then I have a short little leash to get these people an MRI, because I can see peroneal tendon pathology. I can evaluate the ligaments. I can see osteochondral defects. I can evaluate the syndesmosis. I can get kind of a broad range of information to make sure that if there is something hiding under there, that I'm not missing it. So what was your thinking for getting a CT scan also?
That's a good question. And I guess maybe that's, the part of my question on this is, is it going to add anything more? And the reason oftentimes I will get a CT scan is I feel like especially if there's cystic changes, it gets me a little bit better analysis of like, what's the bone looking like? Am I going to have, like, how big is that? Because sometimes I think the MRI either over or underestimates kind of the bone involvement. And I feel like the CT scan gives me just a little bit more detailed look at what the bone is doing. Because in this case here, there's quite a bit of edema on the T2 images, and so it's one of those things where if you look at that, you think, gosh, that's like a third of the width of the talus. Am I really going to have to be thinking about a oats or something like that in this case? The other question I guess I have for you is, okay, so you have somebody that comes in, like this person kind of came in, they have the x-rays, but it's not uncommon that they come in, they get x-rays, and they are, you don't see anything. X-rays are negative. At what point are you going to get an MRI? Is it, on these patients, I'll oftentimes put them into PT, get them in a good functional rehab. I'll make sure that the clinical exam fits with a lateral ankle sprain. Yeah. Maybe if they're having medial pain, I'm probably going to get an MRI almost immediately. But let's say that all fits together, at what point are you getting a MRI if they're still having pain?
It kind of depends on the patient to me. If it's kind of your average middle-aged person, which unfortunately I turn 40 next month, so I get lumped right in with the middle-aged patient profile. So if it's a middle-aged patient, I kind of let them ride for maybe about 6 weeks or so. If it's a younger patient and they're an athlete and they're begging me, hey, can you get me back to sport? I have games coming up, I have practices, whatever. I'll go ahead and order the MRI ahead of time, because this, I'm preaching to the choir. Any delay in diagnosis is a delay potentially in treatment. So I kind of order the MRI sooner on athletes than I would on the average population. If it's an average person, I just tell them, hey, chances are it's an ankle sprain. Let's see how you do. Let's rehab. Let's immobilize for as short a period of time as we can get your pain under control and then get you moving again. And most of the time, I tell people, the vast majority, 95% of the time, pain's going to go away. You're going to return to your normal activity. That doesn't mean you're fully healed at 6 weeks, but it should be quite a bit better. Yeah. And if the symptoms are lingering and if it just doesn't seem to be turning the corner on those patients, then I'll order the MRI. What's your time frame?
Yeah, it's about the same. I think a lot of these cases I'll see back in 6 weeks, maybe sometimes even 3 months, I think is reasonable. Because I think, usually by then, and I tell them too, that you should be pretty good by about 6 weeks. Let's schedule a follow-up appointment at 3 months and make sure you're good. If you're doing fine, you can call and cancel, that kind of thing. And then say, like, if you get 6 weeks in and you're still having a lot of dysfunction, you're still having a lot of pain and you just can't progress and you feel like you've plateaued, you need to come back and we need to, look into this further. And a lot of them have physical therapists that are really in tune as well. That's part of the other reason I like them with physical therapy, because they get that kind of feedback on a little more immediate basis of, this is looking like it's supposed to, or this isn't really behaving like I would expect it to. I think you need to get some more imaging.
Yeah. So for those just listening, we're looking at MRI sequences with a lateral talar dome osteochondral defect. But you're right. There is a lot of marrow edema, which kind of fits with an injury, but it also kind of muddies the water in terms of trying to figure out how big is that lesion. Is that subchondral edema that I'm seeing for the most part, and really the osteochondral defect aspect is much smaller, or is the defect that large and I need to have a completely different plan in place? So we'll talk about treatment here in a minute, but I think having an accurate diagnosis with the MRI, or in your case, a CT scan as well, may change the treatment outcome. So let's jump ahead to this CT here. So what do you see here on the CT scan that really gives you more information than what you obtained from the MRI?
Well, I think a little bit, you see quite a bit of cystic changes, particularly where that primary defect is there. You see a pretty big or sizable defect. The total area was like, I think it was 130, 140, something like that, like just underneath this 150 mark that we kind of talk about, And so I think
talk about that real quick, because I do have some students listening. So talk about the 150 mark and what
that's kind of the number that we use, maybe a little bit arbitrarily, but we use to say if you can get away with or do like a microfracture, marrow stimulation, through an arthroscope. Anything bigger than that, a lot of times we talk about doing an OATS or something to kind of that's a little bit more invasive type of procedure, where you're actually getting either an allograft or an autograft and putting a chunk of cartilage, for lack of a better term, into that defect. That's always been my number that I've kind of looked at to have to make that decision. I don't know if it's going to change as we think more through options such as bone grafting and some of these particulate or micronized, allograft options as well, because I think that's becoming more popular. And part of the thing I like about that option, at least in this case, is like, even if it was a little bit bigger, is you don't really burn any bridges. You can do it pretty much through the scope, or maybe an open, because in this case you're probably doing collateral ligament repair because she's got some instability. So you'd have a pretty good access at it through that lateral incision. As you talk about an OATS in this case, that's a big surgery, and it's one of those cases where you're signing them up for, you've kind of burned, I don't say burned all your bridges, but you've done a pretty big incision to do that, and you're using an allograft, and I think that some of the results from that can be sometimes a little bit unpredictable as well. So I'm pretty aggressive, I guess, with arthroscopic debridement. In this case, I'm thinking I'm going to use some form or be consented for some form of cancellous allograft. And then I usually use some sort of micronized cartilage allograft on the top of that, like a biocartilage. I don't know, like what your approach would be in this case.
Yeah, I do the exact same thing. And my cutoff for jumping to an OATS is failure of the primary procedure.
Yeah.
And I agree with you. I think the, the 1.5 size is a little bit arbitrary. I think before, when we were just microfracturing and relying on cartilage to fill in the gap, the fibrocartilage, as opposed to the hyaline cartilage, maybe they didn't do quite as well with a larger defect. But with the advent of the juvenile, the minced cartilage products in there, I've tackled some pretty big lesions that have done just fine. So maybe it's how we're tackling it that makes the 1.5 a little arbitrary. But yeah, I'll tackle pretty big lesions. The caveat to that, it gets a little more, not a little, gets a lot more complicated if it's a true shoulder lesion. If the defect actually entails the entire shoulder of the talus, then the cartilage graft does not want to sit very well, wants to fall into the gutter. That's a little bit more tricky. You're going to be looking at maybe some sort of larger graft at that point. But I'll tackle large defects through the scope, microfracture, and then the juvenile cartilage, like you said.
I think they talk about that with shoulder lesions, like these shoulder lesions, and I never really know where they all seem like they're shoulder lesions, at least that. And so there's always some of this kind of uncertainty when you put it in that, hey, is this really going to work or not? And so I struggle just a little bit with that to know what's a true shoulder lesion and what's not. So. Sure. Even in like the ones that I'm like, I don't know if that's how great that is, how great our shoulder is, and maybe it's there's more there than meets the eye on some of these. But even in those cases, I've been not disappointed with it. And like you said, some of these really big lesions, I've been impressed with how they've done clinically.
Yeah. So. Let's say that they failed this. Let's say that they, luckily, knock on wood, that they don't fail. But let's say they did fail. Would you try it again, or would you do more subchondral drilling, or would you then jump to an OATS with a malleolar takedown and just jump right to that? Or in residency, we did a cadaveric talar allograft wedge. So we had a fresh talus, cut out a wedge that matched, CT guided, matched to the shoulder, and then used these little osteochondral darts in there. It never lines up quite like you want it to. In a perfect world, it looks perfect, but there's always like a little dip, a little, it's just off, it's not quite right, and you're like, that might be a source of failure there. But so what would you do if they came in with continued pain?
I guess it depends on what the imaging looks like. At that point, you're repeating MRI and CT scans, and so if it looks like there's, there's maybe just some unstable cartilage there that you can go in and scope and clean up, and the rest of it doesn't look terribly edematous, I might go with that. So, a little more lesser invasive kind of thing. If it comes in and now, if they come in and now they have like a big lesion, this big cystic lesion, and it's gotten bigger. I think at that point, you're probably doing an OATS of some sorts. And you're right. When you do that, you try to match, whenever we match the CT in these cases, it's always a little bit challenging or tricky to get it kind of lined up perfectly and get your cuts perfectly. And I feel like anytime you do these, then you open it and you've done a pretty big dissection to get to it. And then you look at it and you think, that's it. It feels like such a small area.
Yeah.
And so like on something, let's say it comes down the shoulder, then I'm taking like a, kind of almost freehand cutting, a block to kind of fit that. And then you got to, do your resection and make it match. And that's never quite as straightforward as you might like it to be. If it's still pretty good shoulder, then I think I go to like a true OATS where you're taking your plugs. And I think that's a good option to do as well.
Mm-hmm. So, what are your thoughts on, have you moved towards using a nanoscope? I'm trying not to use any trade names, but anyways, an in-office, very small arthroscopic system. If they were to come in, I mean, I've thought about using this as more of a diagnostic tool compared to MRI. If you could stick a scope in there under local anesthesia in the office and get kind of a true visualization of the defects, maybe you wouldn't need an MRI, maybe you wouldn't need a CT scan. But then again, as I'm talking out loud, you kind of do like to know the depth, and maybe you can't appreciate any of that. So maybe that would be reserved for evaluation of someone who's having continued symptoms as opposed to the primary, because you wouldn't be able to repair it during the primary evaluation.
Yeah, I think we're still figuring out where that fits into everything. The in-office nanoscope. I mean, there's definitely some cool technology out there, but figuring out where it falls in. I have used a nanoscope, a few times, and it's a cool instrument. I mean, it's a slick instrument. You have to get used to, and I think they're working on upgrading, but changing some of the technology. But it's a 0-degree scope. So I use like that 30-degree scope is, even though it's hard to, when you first learn on it, it feels a little weird. It's actually a great tool because you can kind of look down from the corners. You're coming in straight on in. And so I really rely on that ability to use a 30-degree scope, or even sometimes a 70-degree scope, to be able to kind of look almost, around corners. And so that's a little bit of the challenge with it. But the nice thing about the nanoscope is it's super small, it's super slick. And it has really high quality images as well. So there's definitely this role. I think we're kind of figuring out where that's gonna fall into everything.
Sure. So, treatment wise, I kind of threw these kind of videos in there just for clarity's sake for anybody watching on the YouTube. So this is what's called a power pick. I've used it in the past. I've kind of moved away from using it. What do you use for your microfracture?
So kind of interesting. I've kind of gone away from microfracture. Maybe I've just talked to too many of my knee colleagues, where I'll be more likely to do a scope and just debride it and maybe curette it a little bit. But and then if I'm doing, where I will use a microfracture is if I'm going to fill it. Because I do want some bleeding bone. But if I know I'm going to fill it either with like this minced cartilage that we were talking about, or even like an autograft scenario and then minced cartilage on the top, then I will drill it. But if I go in and I see like a small lesion, for example, I'll debride it, and I probably won't even drill it in that case.
So this is the power pick, and I used to use this, but what I found was that I could only get it to go in at one specific angle through the portal. It was hard for me to kind of get in and come back at it or change angles very easily. And so I went back old school, just using an awl and a mallet and I could just angle the awl and kind of hit all directions. So kind of coming full circle there. So this is a arthroscopic image of a debrided kind of osteochondral defect near the shoulder, but some of that lateral most aspect of the shoulder was still intact. So hopefully the graft doesn't fall down into the gutter. And then this is the minced cartilage, the juvenile cartilage products coming in. Is this what you use as well?
Yeah, very similar. And going back to your previous image, I mean, that's what pretty much they all look like. And it's nice to hear other people kind of say the same thing, that because in that case, I'm like, I have enough here that I can there's enough of a shoulder that I can fill into that space. If it goes down much farther, then you're starting to lose some of that structural integrity. But yeah, exactly like this, where we clean it up. I do drill it in this case, and then put your gooey material on top of it.
Yeah, so the hardest part of this case for me is trying to dry out the ankle, because you just drilled a bunch of holes in the defect. It's bleeding. You turn off your fluid, you dry it out. So with the pressure, the intracapsular pressure here with the fluid is keeping all the blood inside. You can see it doesn't look like it's bleeding. As soon as I take the fluid out, you can see how much bleeding there is with the subchondral bone. So
which you want to see. Like, you're glad to see it, but you're a little sad at the same point, because you know it's going to be hard to see.
Exactly. So, and then, you end up using only everything on here is so magnified. You end up using just a little tiny bit of this, a little tiny bit of that. I use a wet freer. So have them dunk the freer in saline so it doesn't stick to the cartilage, to mat it down, smooth it out, and then fibrin glue. The fibrin glue comes with this flexible tip you can see here, which I absolutely hate. So I've moved to using an 18 gauge needle.
Yep.
Which goes on the tip, and then the portal sometimes and the capsule will fight against you and bend the flexible tip, and I can't get it in. So the 18 gauge needle goes in, and it doesn't fight that anymore. So
yeah, that's a good tip. I think that's been a helpful one. Something, putting something metal on there, or even the if you don't want the needle or the point, you can use a just the syringe that you're going to draw fluid up. That blunt tip, 18 gauge.
Yep, that's a good idea too. So we'll pretend that this is your patient, and we'll pretend that.
Well, I haven't done this one yet, but I saw it, and I thought this will be an interesting discussion because. So how often are you using like an autograft, like to do bone work in
autograft?
In this case? Yeah, like putting cancellous autograft, like bone chips or something into that defect, or are you going pretty much straight to this minced cartilage?
I go straight to the cartilage, no, without any rhyme or reason. I just open, find the weak spot, stick my probe on there, find the defect. If you can't see it, sometimes you'll be scraping along and there'll just be kind of a soft spot.
Yeah,
I'm not talking to you. I'm talking to the average person listening. There'll be a little soft spot. You'll identify your defect there, and you'll know to start poking holes in that, debriding it, getting it out of there. But typically, I don't use any autograft. Are you using that just to kind of fill up if it's a deep enough void to get it to the surface, or what's your thought process behind that?
Yeah, I guess, maybe a little bit of that. It depends. Like, it has to be a pretty big lesion, I would think, to be able to kind of, because sometimes you get in there and you clean it out and you're like, and I'm having consented for an autograft to fill, because I think it's going to be a big defect and it's going to be a big space to fill with just this cartilage, right? So, and sometimes I'm a little surprised. I get in there and I think, oh, this is actually not quite as deep as I thought it was going to be. But I do that a little bit off of the coattails. I think there's a study out there, but like Dr. Porter in Indianapolis has talked about using just iliac crest autograft for some of these instead of, or maybe in addition to using the minced cartilage. And so I think it's kind of it's an interesting idea. And this is probably a little bit shallow, like this particular case that you're showing. That's
sure.
Pretty shallow. But if it gets deeper and you have a big cyst, I think at times I will use some autograft to fill that initially, and then put the minced cartilage on top.
I think that's a good tip. Are you harvesting from the calcaneus?
I think you could do whatever, wherever you want to do it. And sometimes you can do, because a lot of these cases I'm using bone marrow aspirate. And, I used to go to the iliac crest and take it from there. What I've actually found now is I can go to the proximal tibia. I can get enough bone marrow aspirate to use with the with this allograft, with the cartilage allograft. And then you can use the jam shading needle to actually take some cores of graft. You can get a little bit of that bone graft, and then that's usually enough for these defects. You don't need a ton. And then you're not making like a huge hole. It's just kind of a, whatever that gauge needle is. And you can use that similar to like, if you're doing like fifth metatarsal fracture, sometimes you can use that technique to get some core of autograft and then you use that to actually fill in the defect on the fifth metatarsal.
Yeah, that makes a lot of sense. What's your role for retrograde drilling?
I was going to ask you. You can't do that. That was my question.
I've never been able to make this make sense in terms of either there's an osteochondral defect or there's a subchondral cyst. And if we do retrograde drilling, we're going to kind of, maybe if it's like a Burton Hardy 1 where there's that cartilage cap that's still intact, but there's a subchondral injury and I don't want to violate the intact cartilage, I can go retrograde, use an ACL guide to target it, retrograde drill right behind it and backfill it. But I've never kind of found myself doing that. I just find the soft spot. I go through maybe it's because of the advent of this cartilage product. I don't have any problem just going right through the cartilage, even if it is an intact cap, to get to the subchondral bone. But what are your thoughts?
I think I totally agree. I have had the exact same thoughts. I have used it more recently in that younger patient that comes in. Oftentimes it's that medial osteochondral lesion. And I can think of a couple of like in their teens that have that medial injury with some bone edema, and you scope them and you see that the cartilage cap is totally intact. And I can think of one in particular in which I thought, man, this looks so big on the MRI that if I take it down, I'm going to be left with this huge hole. And I scoped it, and it already had another scope done elsewhere, and then had a just like a lateral ligament, but was still having pain. So I scoped it. I cleaned up a little bit of, fibrosis, scarring, and then, found where the cartilage area was on the MRI, and it was fine. And it didn't have it. If it had it, it was a little soft. There was maybe one little spot, but I thought, man, if I go in and I take this down, now I'm looking at a really, really big defect to really get down to where things look normal on the MRI. So I retrograde drilled. Those are ones in which I would retrograde drill, because it's a big enough area that I can get to. I think it's a little bit hard to know if you're in the correct spot or not. They have like these GPS, these guides that you can use, but it's a fairly far distant area, relatively speaking, and it's usually a bit of an awkward angle. And then you're using a 1.6 millimeter wire, so it can really you get it off just a couple millimeters, and now you're totally missing that spot. So sometimes it's a lot of really planning it out beforehand, knowing where you're going to want to put that wire under your x-ray, and then having fluoro and doing multiple passes. And that's the case where then I'll drill underneath it and use some bone marrow aspirate and maybe some BMP or DBM and inject into that area to try to get some kind of just stimulate a little bit of a healing response. And it seems to work.
Yeah, I think that makes sense. So I don't do that often, the retrograde drilling, but that case scenario makes a lot of sense.
Yeah, it's not that often of times that you're going to run into that kind of scenario, I think.
Right. All right, so let's jump into this second case here. Why don't you talk us through that? All
right, so this is a gentleman with history of multiple sprains. He's late 40s, early 50s, and he's very active, enjoys hiking and doing a little bit of running, works out almost a couple days a week, but has a history of rolling his ankles. And then really it got a lot worse recently. Had a bad ankle sprain onto one side. Both the ankles are affected, but the right one in particular seems to be bothersome. And he's got to wear a brace all the time. Like he comes in, he's wearing braces on both sides. You've seen this patient, and he's like, I am deathly afraid that if I go anywhere without the braces, I'm going to roll my ankles. Yeah. And he's otherwise pretty healthy. And on your exam, there's a lot of instability of the ankle, meaning, I'll say, not to you, I'm not talking to you, I'm talking to maybe the students, but their anterior drawer is 2+. Have a good endpoint on the anterior drawer, and the lateral tilt, you can just feel that talus kind of knocking back and forth. He's got some swelling in that area on the lateral side. He doesn't have any peroneal tendon instability. What I mean by that is when I do circumduction testing, he's weak, and I cannot elicit any instability or dislocations of the peroneal tendons.
No subluxation there.
No subluxation. But, on his exam, the other thing that was kind of interesting on his exam, you look at his x-rays, and as we'll do here in a second, and he looks fairly neutral. Doesn't look like he's got too much deformity, but when you look at him, he looks like he's got some subtle cavus. He's got, almost this plantar flex first ray. And looking at him from behind, he doesn't have a ton of varus of his heel, but he definitely feels like he's got some cavus into his feet. And he kind of says, yeah, I've always had these high arches. They don't look that bad, I don't think, on these x-rays, really.
Yeah.
And I don't have a Saltzman view here, but yeah, see, you're pointing out his ossicle or something that's going on the lateral side.
So maybe like a chronic subfibular ossicle, or maybe like a historical avulsion injury. I'm never quite certain when I see that, but draws your eye there. And so, you might get thrown off a little bit there and say, oh, well, you have this little ossicle here. That's what's driving your pain. So just keep that in mind, that it may or may not be contributing to any amount of lateral gutter impingement or subfibular pain.
Well, I think it's important to know it's there too, because, you know, when you get into these cases, it helps if you're looking for that. And then sometimes if that piece is pretty big, sometimes it's a little bit harder to get the repair that you want, because now you've lost some of that structure.
We also don't, if you are going to do a lateral ankle reconstruction, we'll get to what happens with this case, but if you are going to do a lateral ankle reconstruction, you don't want to leave that piece there, because you're going to drill your little anchor into this weak little subfibular ossicle. It's not going to have any pull. So you do need to take that piece out if you're going to be doing lateral ankle reconstruction with anchor.
And in his case, I mean, he obviously goes to surgery, but in his case, you could see it through the scope, you know, when I come over the top and you're like, oh, yep, here's that piece. And it was enough of an intra-articular piece that you weren't going to miss it. But there can be some cases where you kind of have to work to find it a little bit. It takes a little bit of time to find it off the fibula.
Yeah, for sure. So you got an MRI here. We're going to evaluate the specific.
I think he came with it, but you know, this type of person, you know, when he's that unstable and he's having that much pain and he has a history of instability, you know, he says, I've been in tons of physical therapy. It feels extremely weak now. That's a situation in which I'm probably not going to put him back into physical therapy again. You know, if he hasn't, it's one thing if he hasn't done it at all, but if he's already been doing it and I'm seeing him for the first time, I'm going to get an MRI in this situation. Do you ever get ultrasound if you're suspicious of peroneal tendons? Is ultrasound play a role for you at all?
So no, but I want it to be. I want to get my own ultrasound, teach myself, and get very good at it, because I think that would be a fantastic utilization of healthcare dollars, or I should say, not utilization of healthcare dollars. If I could do an in-office ultrasound, save the MRI, look at that, one pass of that, you either have to identify, is it normal or is it not normal? Because when I evaluate peroneal tendons on MRI, half the time I'm like, what am I looking at here? Is it like flattened? Is it, you know, you can tell if something's normal or not normal, but I've been fooled. Sometimes I think it's one thing on the MRI, get in there and it's something completely different or way worse or not quite as bad in the actual clinical scenario. So I think there's a threshold you meet there for saying, hey, you've had this pain for such a long period of time. Let's check to see if something is pathologic or abnormal. Quick swipe of the ultrasound. Yeah, that doesn't look right. We're going to surgery whether I get an MRI or not, because I can see it more clearly. I tell patients the MRI is like the TV, the rabbit ears from the 1980s, where it's all fuzzy and black and white. And when I go into surgery, it's 4K, it's HD. I can see the difference between the old fuzzy black and white image and color crystal clear when I go in and see it. So what are your thoughts on ultrasound?
Yeah, I think I use it some. I don't, you know, I'll use it for some of my injections. I'll use it in some of these, you know, like the Achilles that comes in that you get an x-ray and you're like, probably don't need an MRI, but I just want to make sure I know how far distal it is, or, you know, that kind of scenario it's really helpful for. You know, for peroneal tendon dislocations, if you're suspicious of the peroneal tendons dislocating, that's a really great one to see under MRI. Occasionally I'll use it for some tendon sheath injections, particularly like a diagnostic situation. If I'm trying to diagnose where their pain is coming from and it's not necessarily that clear, even just like lidocaine or marcaine into the tendon sheath can be really helpful as well. So I definitely I use it maybe more now than I have in the past, and it can be a helpful tool. I think I wish I was better at looking at the peroneals, because like you said, the MRI can be really it can tell you there's something going on there. You know, the way we all have our own analogies. Sometimes the way I'll describe this, the peroneal tendons is, you know, I have a lot of patients, you probably do too, that have had rotator cuff problems. And they oftentimes tell you, yeah, the doctor said it was way worse than he thought it was going to be, or it was not as bad. And I say, this is kind of like the rotator cuff of the ankle. You know, sometimes we get in there and it looks way worse than we think. Sometimes we get in there, it doesn't look as bad as the MRI would seem to indicate. So it's one of those, it can be challenging.
I think sometimes surgeons just want extra credit, though. They want it to be the worst they've ever seen, and that.
Well, there is some gamesmanship there for sure. Yes, yeah.
This is
Like
the worst I've ever seen.
my favorite are, see some of these ankle fractures that come in, and now they have some post-traumatic arthritis, and they'll have like 2 screws, right? Yeah. 2 screws in the medial malleus. And they'll say, my doctor said this was the worst ankle fracture they've ever seen. And I thought, I always think your doctor was such a good gamesman, because I probably wasn't true necessarily. But there's part of that. They hear certain things too, right? We all hear different things, and it could be that it really wasn't as bad as they think. But that's part of the game.
It probably wasn't even the worst one they saw that day. They took all the patients back. All right, so we're looking at the MRI here, T2.
So this one's actually pretty good, right?
Yeah.
Like your T1, especially that sagittal T2 image, you really see it there. It's almost like this. I was thinking about this the other day. It kind of reminds me of like a snake. So I was thinking you could almost call this like the parcel tongue finding, or the Slytherin finding, because it looks like, right there, you kind of see this wavy appearance of the peroneals. And when you see that on that sagittal, you can almost guarantee that that's a full disruption. Sometimes they get a little bit vague on the reading, like cannot exclude a complete disruption. I think in this case, they called it as a complete tear of peroneus longus, I believe is what they said. Yeah. But if you see that, then you need to be thinking this is going to be totally torn when I get into surgery.
Sure. So when we go back to this image here on the left of this MRI, so I teach the students and talk to the patients. We're at the kind of the wrong level, but if you go to the correct level, you'll kind of see the tibialis posterior and the flexor digitorum longus. Anyways, the 2 tendons on the medial side that form like a snowman or an 8, and that's what they should look like on the lateral side too. The peroneus longus and the peroneus brevis should form 2 black circles that are hugging next to each other. It kind of looks like a snowman or an 8. And when we see disruption of that, it's hard to evaluate. But if I don't see those 2 round tendons forming next to each other, I know something is wrong. A lot of times I get tricked because commonly it's the peroneus brevis that flattens and it's no longer tubular. So it's flat and it's hugging against the longus. So it almost looks like one tendon because you have the longus that's intact and the brevis that's torn, and it's making this little C shape hugging against the longus. So, but typically you can notice if something is pathologic.
And you could have a fairly, like a lot of the brevis, like they're fairly flat, but when you get the split tear and the longus kind of goes into the brevis, and now you kind of have it sitting on either side. You can't, because sometimes that too gets dictated or read as a quartus. In that situation as well. So you just have to be kind of aware of the different possibilities that you can see, but it is tough to tell. The other thing, and the image here that you have pulled up is pretty good, for the students that are listening. What I tell them when you're looking at like ATFL, for example, if you get down to the level where the fibula turns into a kidney bean. Now, I didn't come up with this, but somebody, I think I saw this on Twitter. So, you can learn something. But when you get down to the level where the fibula turns into this kidney bean shape, that's where you should see ATFL attaching to the talus. That's about that right level. So if you sometimes you have to go up and down a little bit, but if you could just start practicing on your normal MRIs that you're getting, finding the kidney bean, finding the ATFL, then you're going to start to pick it out, like when it looks abnormal, as in this case, like it just looks funny there, and you have that little piece of bone that's like in that recess. But that's another helpful tool. So you can see the peroneal tendons, you can see the ATFL. We haven't even really talked about the cartilage, but that's kind of those are the big 3 that you're really looking at in this type of setting.
Mm-hmm. Yeah. So what's your plan for this patient then? Because obviously we know there's some peroneal tendon pathology, and what's your go-to? Because I scope every one of these. So what's your plan?
I scope them all too, and assess the cartilage. I think a lot of it, sometimes there is going to be, I think I said he's in his 50s, early 50s. So if you've had multiple ankle sprains, you're probably going to have a little bit of irregularity to the cartilage. So I'll scope it. I'll clean up any, areas. in this particular patient, just age-wise, I'm probably not, if you find something articular, I'm probably just going to debride it. I'm probably not going to get overly aggressive with doing marrow stimulation or even like a biocartilage. Because I think at that point it becomes more of an arthritic process than it is like actually true osteochondral lesion. Because that we talked about that a little bit. We didn't get into that part of it, but sometimes you see these patients come in and they have dual medial and lateral osteochondral lesions. That's arthritis. Like if they're over the age of 40 and they have that, that's unfortunately just arthritis. And I don't think there's anything you could do to save that. Sure. But in this case here, I'm scoping him. I'm getting a good look at the cartilage. I can look at the you can look at the deltoid. You can look at the syndesmosis. Fortunately, in that case, this was all, it was okay. And then you can see kind of like, if you don't know if you go back a little bit or not, you can see where that little piece was kind of in the anterolateral recess. And, so the scope had a lot right there. The scope had a lot of inflammatory synovitis. It almost looked like a light beer as the fluid kind of came out of the ankle joint. So a lot of synovitis, as you can see, all that white is all synovitis. So we scoped it, we cleaned it up, got a good look at the deltoid. Deltoid looked okay. And we got a good look at the lateral ligaments. And then we went ahead and I do an open repair on the collateral ligament reconstruction. I know some people do arthroscopic, but in this case, I want to look at the peroneal tendons. What I thought was kind of interesting is this is my lateral incision, and I usually make a little window into the peroneal so that I can put a retractor in front of them when I'm doing my ATFL and CFL repair. And that way I just retract them out of the way. But I made my window and out popped the end of the peroneus longus, I'm assuming. And that's what popped out initially. And so I was like, all right, well, now we know kind of what we're doing in the full scope, because we're going to be doing some sort of repair on this in this case.
Yeah.
So that's my initial visualization. And then this is kind of after you extend the retinaculum both proximally and distally. And so what I'm holding there is the base, basically the peroneus brevis, whatever was left. And then the longus is kind of flipped out of the wound there. And so I think what happened was that longus, that's what tore it. Right as it goes underneath the cuboid. I think it was overworking because it was basically providing all the support, because peroneus brevis was basically dysfunctional in this case. So what I did was basically tag peroneus longus, and then I did essentially a tenodesis or transfer of the longus to the base of the brevis in this particular case. And I did that with a collateral ligament reconstruction. And so I used a augmented reconstruction to stabilize the ankle. And I think that combined with the peroneus longus to brevis gives enough stability that kind of takes some of the stress off of the peroneal tendons in this case. I'm curious as to what you think in terms of how you would manage this, because there's a lot of questions about, are you doing a tendon transfer? Some people talk about transferring FHL for peroneal tendon dysfunction. They're talking about using allograft tendons. There's these grafts that you can use, whether it's, these like the Artelon, or you have the BioBrace, or you have like an Arthroflex, like all different types of grafts that you can use to augment these peroneal tendons. How are you approaching those?
Yeah, I don't deal with the peroneus longus tear very often. I deal with peroneus brevis tears all day long. So that's a little bit easier in that typically it's not a complete tear. Typically it's flattened and partial thickness tearing, and I need to debride, tubularize, and then I wrap it with Arthroflex. This is much more complicated because, like you said, the peroneus longus tends to rupture at the cuboid as it's coursing underneath the foot. And if it tears distal, where it typically does, there's not a whole lot you can do because it's going to be really, really hard to find the distal stump of that tendon without making a huge incision and tracing it, try to find it, to be able to reattach that with some sort of, suture, and then Arthroflex or a cadaveric graft or something like that. So I was thinking about this after you sent the case, and I was thinking, I think tenodesis is really your go-to procedure here. I couldn't even really think for a second. I was like, well, maybe you could do like a tenodesis distally, and then you could use the peroneus longus to do like a modified Christman snook. Like I was just thinking outside of the box of trying to figure out like, what could we do with this silly thing that's just flopping in the wind?
Yeah.
But I think tenodesis is the way to go.
Yeah. It's kind of interesting because as I dissected proximal, I don't have a good picture here, but what was left of attached for the peroneus brevis was really bad. Like I thought maybe I could get up there and get some of that muscle to bring some more strength in, but it had no excursion, where the longus still had really good excursion. And so that's exactly what I did. Is I took the longus and basically tenodesed it all the way down to the brevis. And you could have maybe made an argument to augment it. I could maybe put Arthroflex or some sort of other graft augmentation, allograft, kind of your dealer's choice. I get a little leery in this case because that is so superficial. That any other bulk in that area potentially could create wound healing problems or irritation. So I elected just to do, I basically crack out, you use suture tape to crack out the longus, suture tape to crack out the distal portion of the brevis, and then just basically crossed them over and kind of did a kind of a modified gift box reconstruction, and then added the collateral ligament reconstruction, which I actually think will help quite a bit because now that's going to like take some of the tension and the work out of the peroneal tendons by giving him a more stable ankle. And then I also lifted his first ray up. I did a dorsiflexion producing osteotomy of his first ray just because he still had a little, just on clinical exam, he had a little bit of plantar flexion of the first ray. So I added that into the mix. I didn't think he needed the like a Dwyer calcaneal lateral slide kind of situation.
Sure. So I typically will do the same thing. You can tell looking at this longus that this is chronic. This has become just this fibrosed ball of scar and nothingness. You can tell it hasn't been doing anything for a while. It's just turned yellow and it's going to turn to dust eventually. But what I typically do is I historically, as long as the profile allows, I'll debride a lot of both of them and kind of thin them both out. And then I will wrap the Arthroflex graft around both of them. To kind of, I cross hatch one, kind of get it flat, cross hatch the other, and kind of put them side to side. And then I'll kind of tubularize them as a unit and then wrap it with an Arthroflex so that it does have some excursion and there's that slippery surface on the outside of it. But like you said, if you don't debride it enough, it's going to be huge and it's going to want to sublux and not stay in there. So you end up having to debride quite a bit. So typically those are the ones where they have had so much non-viable tissue that I'm debriding out what doesn't need to be there anyways. And then I can tubularize them and form almost one tendon. That seems to work okay.
Yeah, and these oftentimes too, the other thing you got to look for is they'll have a proud peroneal tubercle. So I will dissect deep. I'll find the peroneal tubercle off the calcaneus, and I'll take a rongeur and I'll smooth that down because I think that is sometimes a source of irritation onto the peroneals and can lead to some of this attritional changes to the tendon over time. So I'll make sure that that's totally smooth as well.
Sure.
And that gives you a little bit of space, I guess, in terms of everything else. So how often are you adding a calcaneal shift, like a Dwyer, in cases like this? I mean, I have a low threshold to do it if it really looks like they have a lot of calcaneal varus, but how are you doing that? And how are you managing it? Because oftentimes you got the lateral wound and now you're doing a shift through another separate lateral, or maybe you're making all through that same incision.
I typically don't jump to that. I mean, if they have an obvious cavus foot deformity, maybe that's different. Are you thinking, is your thought process kind of similar to when we do a posterior tibial tendon repair / FDL tendon transfer, and we do a medial calc slide to kind of protect the tendon repair on the medial aspect?
Yeah, that same kind of question. Yeah,
that's a good thought. I don't really do that, and maybe I should be to protect the tendon. I guess when I do the lateral ankle reconstruction, I'm using not a Brostrom or Brostrom Gould. I'm using suture anchors, which are less likely to fail in my mind. And if they meet certain criteria, then I'll jump up to like an internal brace instead of just the regular suture anchors to prevent that lateral I'll do the 2 arms from the talus to the fibula, fibula to the calcaneus, reestablish ATFL and CFL. And in my mind, that
with the internal brace, will you do that?
Yeah.
Okay.
So I take 2 arms, start in the talus, go to the fibula, and then go down to the calcaneus. So I have 2 arms between each of those to recreate ATFL and CFL. And the thought process is that I've kind of limited some of the inversion available. Even though I'm going to make them stiff, I'm significantly limiting their inversion to protect the peroneal tendon repair. And I kind of talk to patients. I say, hey, you injured this most likely via residual over and over inversion injuries. We're going to limit some of that inversion to protect the tendon. It's not a bad thought. How often are you doing a Dwyer or some sort of osteotomy?
Well, it seemed to run into it more when I have patients coming in with like true, where I'm saying this, it's a little funny, but it's going to come out funny, but where the true, like the peroneal tendons are the problem. You know, sometimes they have bad peroneal tendons and they don't have that much instability, right? So this guy, I think, had instability leading to the peroneal tendon problems. So by stabilizing them and then, you know, that kind of situation, I've definitely had cases where they have peroneal tendon pathology. It's that thing you were talking about with the peroneus brevis being really bad kind of situation, and it's pain. It's not as much of instability. They're going to have some instability because they're weak, but they come in and they have these cavus feet. And so now you have the challenge I've run into is you have your lateral incision for the peroneal tendons to take care of the painful peroneal tendons. And then what do you do? Like, how do you approach your calcaneal osteotomy? And these are cases where you're like, this is obviously like a cavus foot. You know, this is a situation where they definitely need something to help offload that area. And what I'm doing is I'll use the MIS burr because that's one of the reasons I like it, is because in these cases where I have multiple incisions on the side of the foot, I can get to it in a relatively small incision and still get the shift that I want without having to have that lateral incision, because that can be a problem. That skin bridge gets kind of small and you don't have much room. And I hear some people say, well, I just make one incision and cheat it posterior, and then I get to everything through that, which is not unreasonable either. Kind of whatever works best in your hands. But
I think that makes a whole lot of sense. If they do have that cavus foot deformity, and you're going to, especially with this guy where he's kind of having some dysfunction longest, I think stabilizing that first ray and then doing some lateral column work is very reasonable. So
you might, we're kind of getting in the weeds here. You might argue that because longest is no longer in the picture, that's going to be enough to let that first ray come up, and that might take care of it. Seems like that that makes sense, but it hasn't really borne out quite as well. And I think, healing from a first ray osteotomy should be a relatively benign situation.
Yeah. Well, let's wrap it up there. I've taken up enough of your time. So I really appreciate you hopping on here with us today and talking through some really, really interesting cases. I'd love to have you back on sometime and keep talking through some interesting cases, because I think it'll really help people. So I appreciate your time.
Yeah, well, thanks for having me on. I really enjoyed it. Thanks for all the content and stuff that you're putting out there. Thank you for joining us on ours. I've tried to tag your YouTube show on our posts, and so it was really helpful to talk through that, to talk through tendon transfers.
Yeah, absolutely. That's not necessarily my wheelhouse, but I'm happy to hop on there and throw in my 1 cent worth. I don't even know if I have 2 cents.
Oh no, it was great.
All right. Well, thanks for joining me. Thanks for joining me on another episode of Pod Patrol with your host, Dr. Jeff Dikis, joined by Dr. Nicholas Strasser.